Welcome to Heparin-Induced Thrombocytopenia. This video is the second in a three-part series that will cover heparin-induced thrombocytopenia pathophysiology, diagnosis, and management. In this video, we will discuss Part 2, diagnosis. Let's start with the following take-home points. Calculate the 4T score to establish a pretest probability. If the pretest probability is moderate or high, check a HIT ELISA. If the HIT ELISA is negative, the patient does not have HIT. If the HIT ELISA is not definitive, check a serotonin release assay. Once you have a clinical suspicion for HIT, first calculate the pretest probability. The most commonly used probability score is the 4T score. The first T deals with the extent of thrombocytopenia, which should be a greater than 50% drop with a nadir of greater than 20,000. This finding is assigned 2 points. Assign 1 point for 30 to 50% fall or nadir of 10 to 19,000. 0 points for a fall less than 30% or nadir less than 10,000. The next T is timing. Score 2 points for a fall occurring between 5 to 10 days or less than a day if the patient was previously exposed to heparin in the last 30 days. Assign 1 point if the timing is unclear, the onset is after 10 days, or if less than 24 hours with prior heparin exposure within 30 to 100 days. Assign 0 points for a fall at less than 4 days without recent exposure. The next T is for thrombosis. Assign 2 points if there is a confirmed new thrombosis, skin necrosis, or acute systemic reaction after intravenous unfractionated heparin bolus. Score 1 point for progressive or recurrent thrombosis, non-necrotizing erythematous skin lesions, or suspected thrombosis that has not been proven. The final T is for other. Assign 2 points for no apparent other causes, 1 point for possible other causes, and 0 points for definite other causes. Once you add up the points, if the score tally is 0 to 3, the risk of HIT is less than 1%. If 4 to 5, the risk is 10%. And if 6 to 8, the risk is high. For the low-risk patients, no further diagnostic testing is recommended. For the moderate to high-risk patients, send a serologic assay for anti-heparin PF4 antibodies. The commonly used serologic assay is the enzyme-linked immunosorbent assay, or ELISA. The next step is to interpret the HIT ELISA results. The first rule of thumb is that a negative HIT ELISA stops testing. No matter the initial pretest probability, the patient does not have HIT. Let's look at this more closely in a table format. If you start with a low 4T score, the risk is less than 1%. With a negative HIT ELISA, you can stop testing. The patient does not have HIT. With an intermediate pretest probability with a 10% chance of HIT, a negative ELISA means stop. The patient does not have HIT. In a patient with a high pretest probability and a 50% risk of HIT, a negative ELISA is also reassuring that you can stop testing. The patient does not have HIT. The second rule of thumb is that if the ELISA result is definitive, you can stop testing because you are confident of your clinical diagnosis. To illustrate this rule, let's return to our table. We previously demonstrated that for a low pretest probability with a low chance of HIT, a negative result confirms your pretest probability and you can stop testing because the patient does not have HIT. For an intermediate pretest probability patient with a moderate chance of HIT, a high positive ELISA result confirms the diagnosis and you can stop testing. The patient likely has HIT. For a patient with a high pretest probability and a high risk of HIT, a high positive result confirms your initial suspicion. No further testing is needed. The previous two rules avoid the need for a confirmatory serotonin release assay, or SRA, because no matter the SRA result, the clinical decision does not change. The third rule of thumb tells us that if the ELISA is not definitive, check a serotonin release assay. Let's illustrate this in our table. In a low-risk patient with a low chance of HIT, any positive result is a surprise. If it's low positive, it could probably be a false positive result, but you are obliged to order the SRA. In an intermediate probability patient With a moderate chance of HIT, a low positive result may indicate a false positive, but you can't be sure, so you need to order the SRA. In a high probability patient with a high risk of HIT, a low positive result is a surprise, and you will need to order a serotonin release assay. In any of the three scenarios in which you need to order an SRA, note that the SRA result is your final decision maker. In summary, to diagnose HIT, you first calculate the 4T score to establish a pretest probability. If the pretest probability is moderate or high, check a HIT ELISA. If the HIT ELISA is negative, the patient does not have HIT. If the ELISA is not definitive, check a serotonin release assay, which is your final decision maker. This brings us to the end of Part 2, Diagnosis, in our three-part series on heparin-induced thrombocytopenia.